It's really a pleasure and an honor to be here at the PIDSP conference, and I know that I'm giving a talk after lunch. In the US, talks after lunch are typically talks that are hard to stay awake for. So I hope I'm able to give a talk that's worthy of the hot pink that surrounds us all here at PIDSP. And first off, I want to thank the folks at PIDSP for inviting me here, particularly Dr. Sally Gachalian. I met Sally last year when I was in the Philippines for another reason, and was immediately taken, not just with her energy and passion for children, but with all of the women and men that I've met here in the Philippines. So it's really an honor for me today to be able to talk. I tend to talk very fast, so I apologize. If I'm talking too fast, please put your hand up and let me know. The other thing I just wanted to mention is that I'm going to talk today about a really serious problem in the Philippines, and that problem is drug-resistant tuberculosis. We don't hear as much about drug-resistant tuberculosis as we do about things like Ebola, but I can tell you there are many more people in this country that are right now sick and dying with drug-resistant TB, and the people who are getting the worst end of things are the children. So I'm going to talk today about gaps in practice and things we need to do to improve care, not as a criticism for what's happening in the Philippines, but just as a hope that all the great energy I've seen every time I've been in this country will allow us together to come up with ways to improve the treatment for kids with drug-resistant tuberculosis. So, and I also want to mention I was really inspired looking at some of the posters out there, at some of the expertise that you already have here in the Philippines. Particularly, there was a poster by Josephine Aldaba about some really interesting case-finding methods for pediatric tuberculosis out in Batangas, where she showed in the work that she's presenting that simple things like making sure facilities have tools and drugs to treat kids can increase exponentially the number of TB cases that are found and that are successfully treated. So with that in mind, I'd like to talk to you today about the problem of drug-resistant tuberculosis in children in particular. Sorry, I'm not very good with technology or microphones, so forgive me. So I wanted to start by showing you a picture. This is of an MDR, oh sorry, I told you I'd be bad at this. This is an MDR TB patient in the country of Bangladesh. And the patient, is this the pointer? Ah, it is. So the patient is this lovely woman here in the green sari. But this is actually everyone who's been affected by drug-resistant tuberculosis in her household. Okay, you can see that there are many children running around. You can see that there are other adults running around. And what I will tell you today is that what we know about the number of children with drug-resistant TB in the world is the tip of the iceberg. Any household in which there's an adult who's diagnosed with drug-resistant TB is a household where the children suffer. Okay, they suffer because their parents lose income and they lose the ability to take care of the children. They suffer because they're infected with the bacillus and they're at risk for developing disease. And they suffer because they themselves do have disease. And we're going to talk about how to help them in all those regards. So my objective today is really to talk about best practices on the diagnosis and treatment as well as the prevention of drug-resistant TB in children. I'll be talking a little bit about new tools and strategies, as well as some of the challenges that we face in implementation. Because I think many of us understand the concept that if we have drug-resistant TB in adults, we're going to have drug-resistant TB in children. But we're a little stuck as to what to do about that and how best to treat those children. So often you'll have someone like me who's supposedly an expert on drug-resistant TB in children, and we stand up in front of, I have to say, a really large and daunting audience. And we talk about all the problems with making a diagnosis and starting children with drug-resistant TB on treatment. And I think by talking about all the problems, we get ourselves in a bad frame of mind, and we end up making it seem like treating children or identifying children with drug-resistant TB is too hard. So I'm not going to talk about all the challenges, but there are some issues that I hope we can explore a little more in detail today. First is around burden of disease estimates, which we're going to talk about. I'm only going to touch base briefly on the current diagnostic situation because Dr. Ama did an excellent and thorough job before me. I want to talk about treatment. I want to talk about the dosing and the formulations of second-line drugs. I want to spend a lot of time talking about prevention today because we forget about the thousands of children who are exposed to drug-resistant TB every year and could benefit from prevention. Much like the champions for vaccines, I want champions to prevent drug-resistant TB in children. I want to talk a little bit about how best to integrate TB and other vertical programs, talk about training and capacity, and then advocacy and fundraising. So one of the first challenges we encounter where we have an opportunity for good innovation is we don't really know the burden of drug-resistant TB in children. For reasons Dr. Amma went into, sometimes getting sputum samples from children is challenging. And so when asked, how many children in the world have MDR TB, the honest answer is, I don't know. Okay, there are older models that used to say you could presume anywhere between 6 and 10% of children, of adult cases of MDR were in children, but those numbers are not really very valid, and they don't take into account the transmission dynamics that occur much more rapidly in our very youngest children. So several colleagues of mine who are very smart modelers have presented in the Lancet last year a couple of papers looking at new estimates for burden of disease. And by their estimate, there are 33,000 children who become sick with drug-resistant TB every single year. Okay, and even if you take the low estimate, the lowest possible estimate of how many children are sick with drug-resistant TB, which is around 25,000 children, there have been fewer than 1,000 children ever treated for drug-resistant TB in the world. So the gap between the number of kids who have DRTB and the number of children who are successfully treated is incredibly low, which means we have a lot of opportunity to do our job better. And again, as I mentioned, we shouldn't just be thinking about the kids who are already sick. We need to think about the kids who are affected and infected. So just to look quickly at the Philippines, last year you had roughly 4,000 cases of drug-resistant TB. Given the average household size in the Philippines, that translates into 13,600 children every single year in need of some kind of intervention for drug-resistant TB. So the need is great. Thankfully, there are a lot of things we can do, and like I said, I know the energy of the PIDSP is going to get these things going. I do want to just mention briefly this issue about diagnosis versus bacteriologic confirmation. I think Dr. Amma expressed it very well, but we often confuse bacteriologic confirmation with a diagnosis, and this happens a lot in drug-resistant TB. Okay, if you are treating only children with bacteriologically confirmed drug-resistant TB, you are missing a majority of the children who have DRTB in your country. So you are grossly undertreating, and as a result of undertreating, kids are being missed and they're dying. Okay, I would actually go so far as to say this is an emergency. Okay, we talk a lot about pan-susceptible TB and overdiagnosis. In many of the countries I go to, they say, oh my gosh, there's an overdiagnosis of TB here. A kid comes in with the sniffles and they get put on isoniazid, rifampin, pyrazinamide, ethambutol. And I know that happens, but I'm telling you, overdiagnosis is not the problem in drug-resistant TB in children. And if you're waiting for bacteriologic confirmation to diagnose them, that you're missing children. You should always try to obtain samples from kids to try to make a diagnosis, but in high-risk kids who are sick, you should almost never wait to start them on therapy. And I'm going to talk about who those high-risk kids are and how you find them. Just briefly, again, Dr. Amma talked about this, but there are a lot of opportunities for innovation in the collection of samples. So in kids, we have to collect samples, and then we have to decide which test we're going to use. I'm only going to tell you our sample collection methods are rather primitive now, although they're getting better. Induced sputum, gastric aspirate, there's something called the lung flute that we use in the US in kids who have cystic fibrosis to help them expectorate sputum. And we often forget to ask older kids to expectorate sputum for us. They can do it usually even as low as the age of 5 or 6. There's a new technology that's not out yet, but that I'm waiting for, is something called the sweet string, where we embed a special string in a piece of candy, and all the kids love candy. They chew the candy, they swallow the string, and you either pull the string back out or you take it from their stool, and then you can look for TB in that string. So it's great. Yeah, the kids like it. And then I'm actually not going to talk about, once you have a sample, what to do with it, other than to stress what Dr. Ama said, which is gene expert, which is a much more sensitive test, should be used instead of smear in all children. Okay, it doesn't matter if this child has a contact or not a contact. Any child that you get a sample from, that sample is precious, is like gold. And you shouldn't waste it on a smear, which is a really low sensitive method. So they should go for expert in culture. We have some hope for other tests in the future, but they're not there yet. The urinary lamb was a test people were talking about a lot, but it's not a very good test yet. So, and then again, I just want to mention this issue of diagnosis. And throughout the slides, you'll see some of my very favorite MDR patients from around the world. And these are 3 children from a family in Georgia. What I will tell you is diagnosing drug-resistant TB in children is relatively straightforward, okay? Bacteriologically confirming it is the most challenging part. But you don't need bacteriologic confirmation in order to move ahead with treatment. And if there's one message I can get across today, I hope it's that message. If you wait for bacteriologic confirmation to treat a child for drug-resistant TB, children die. Okay, so you will need to treat in the absence of bacteriologic confirmation in most cases, but there's a very rational way to do that, and I hope that we'll talk about it. And it largely focuses on a contact history. If you have a child with signs and symptoms of tuberculosis and they have a contact who has documented or suspected drug-resistant TB, you should treat that child for drug-resistant TB until you prove they do not have drug-resistant TB. Okay, we're sort of flipped how we do it now. We say, well, I'll treat them for pan-susceptible disease until I prove they have MDR. No, children die that way, okay? One of the reasons we tend not to treat children for drug-resistant TB isn't because we're not aware of the problem. It's usually because we're really frightened that giving those second-line drugs to children is going to cause them problems. They won't be able to take the drugs, they're going to develop horrible side effects, it's going to be bad. Okay, but what I can tell you is good news. Children who are treated for drug-resistant tuberculosis have outcomes that are far better than those we see in adults, and they tolerate the medications much, much better than adults do as well, with one exception. So a lot of this data comes from a meta-analysis that was done on 318 children who were treated for drug-resistant TB. Their treatment success rate is 80%. That's comparable to adults where the treatment success rate is 60% and actually closer to 50%. Kids do well if you identify them and treat them early. They tolerate the medications much better. They take the pills, even though most of my adult patients won't take them. The kids come in, they take their meds, and they go. And they tolerate the side effects better with one exception, and that exception is hearing loss. Okay, the use of aminoglycosides, which are imperative in the treatment of drug-resistant TB, causes a lot of problems with hearing loss. Now, losing your hearing is better than losing your life. Okay, and I think we always have to contextualize that. The 5-year mortality rate for MDR TB, if left untreated, is 80%. Okay, there is only a 20% 5-year survival rate for MDR if left untreated. It's worse than most cancers. All right, so losing your hearing is better than losing your life, but losing your hearing has really serious implications for children, particularly young children who are developing language skills, who are developing, their place and their role in the world. And what we found is that children who are treated for drug-resistant TB lose their hearing about 1 out of every 4 kids. So this is significant, and we'll talk about some strategies to minimize this, so just keep this in mind. Again, I just want to briefly, I'm having a hard time coordinating myself. Just to briefly mention, who, I use the word suspect because this is old, but who are children who have presumptive MDR TB? These are children who have a history of treatment. Okay, I have to tell you, one of the things I hate the most in the world, and I've been doing MDR for 20 years, I hate Category 2. I hate the retreatment regimen. I think it's a terrible, terrible, terrible treatment regimen, and that's a story for another day. But if you have a child you're seeing and you suspect they have TB, if they've been previously treated, you need to consider MDR. If you have a child who's a close contact with someone who has known MDR, then you need to treat them for MDR if you think they have TB. A brief interlude here is a lot of times people will say, well, I asked and they don't have any contacts with TB or MDR TB. But I think we have to remember as providers the huge amount of stigma that's associated not just with TB, but in particular with drug-resistant TB. Parents may not tell you. They may not want you to know that they have drug-resistant TB or that they've been treated for drug-resistant TB. So just asking the question may not get you the answer that you want. And it's actually really appropriate to talk about this today on Ash Wednesday. My colleague Maricela Glare reminded me that Jesus was the first person to advocate for stigma reduction when he spent time with the lepers. So we just have to remember, parents, it may seem like they're lying to us, but really they're kind of embarrassed. So be careful if they tell you there's no TB contact, and be careful if they tell you there's no MDR contact. What I usually ask is, has anyone in the household been treated for tuberculosis with injections? Because if they've been treated with an injection, they've probably either got MDR or they're on the dreaded category 2, okay? If you have a child who you're treating for pan-susceptible TB and after 2 or 3 months they don't clinically improve, and by clinically improve I almost always mean weight gain. So if you have a child who's being treated for regular TB and they don't gain weight after 2 or 3 months, this child is probably failing their regimen and they're at very high risk for having MDR. What I would say is get sputum samples from these children or whatever sample you need, but don't wait for that sample to come back with confirmation of MDR before you put them on treatment. So just a couple action items. I usually speak to TB providers and not pediatric infectious disease folks. It's nice to be amongst the infectious disease providers because that's where my training is. But one thing I do just want to mention to you guys, the likelihood that you in your practice will be caring for a child with drug-resistant TB is low. Okay, those patients usually get referred to the National TB Program and they undergo programmatic management of drug-resistant TB. But you will care for children with TB in your practice. And I think what you guys should recognize is if you have a child you're treating for TB or you're thinking about treating for TB, ask specifically about any contacts who died, any contacts who received injections. Okay, and if you can elicit that history, that child needs to be assessed for drug-resistant TB, and you need to make a big note and make a phone call to our friends at the National TB Program to tell them, I think I have a kid with drug-resistant TB here. Okay, the default is even kids who have contacts are usually started on first-line therapy, either because the TB program didn't know or they were afraid, and we'll talk about that in a minute. And if you're taking care of kids with TB and they're not gaining weight by the 3rd month, again, you should make the same call, the same referral. When we treat children for drug-resistant TB, we use the same drugs that we use to treat adults with drug-resistant TB. Okay, there's some better work going on to see if we actually need to use as strong of a regimen as we do in adults, but these are the listing of the drugs and with dosing recommendations. It's kind of micrographia, so I apologize for that. This lecture will be made available to all of you. I think PIDSP will make it available, but if not, let me know and I'll give you a copy so that you don't have to write these things down. And then some of us at the group that I work at, the Sentinel Project, actually made a dosing chart. So that there's weight bands here, and you can see how much you have to give to the children. And again, I'm happy to make this chart available to anyone and everyone. One question that arises when we think about treating children for drug-resistant TB, again, everybody worries about the side effects. Well, I don't want to put this kid on therapy for 18 to 24 months. I'm scared about the side effects. I'm scared about the injection. And so several of my colleagues who work in Cape Town, where they treat hundreds of children for drug-resistant TB every year, actually looked at this question. Do children need the same treatment as adults? And the answer is if children have severe disease, they do. Okay, if the disease is severe, they need the same principles. They need at least 6 months of injection. They need at least 18 months with the rest of the drug. But if children have limited disease, if we find children early, if we're doing active household investigations and we find children early, they probably don't need as aggressive of a regimen. Okay, and we'll talk about this both in terms of limiting the duration of the injection and in terms of limiting the duration of therapy. And a lot of this comes from Professor Simone Scopp, a colleague at Cape Town. And Professor Scoff taught me and many others to think about TB and along a spectrum where you have a low bacillary load up to a higher bacillary load. Here we tend to call TB infection or latent TB. Then you'll have children who are presenting with non-severe disease. Then you'll have children who are presenting with severe disease. And they likely need a different approach to the management of drug-resistant TB. Okay, so it's this kid. This kid is so cute. I love this picture. You know, this kid whose mom had MDR, and this child got screened. She wasn't growing normally and, you know, was not well. And they found this on the x-ray, hilar lymphadenopathy, pretty significant. This is pathologic. This kid is very different than this kid. Okay, this poor little boy, I know. This child has drug-resistant TB, and it was missed. And he was treated for pan-susceptible disease by well-meaning providers who did not want to expose him to second-line drugs in the absence of bacteriologic confirmation. And this is what happened to him. Okay, this child can't get treatment for mild disease. He needs 18 to 24 months of therapy with a minimum of 5 drugs and at least 6 months of an injection, okay? But Professor Scoff is a lot smarter than most of us in the world, and he separated these kids out in one of his treatment observation studies where they looked at 149 children. This is in Cape Town. These children were all treated for MDR TB. The median age was 3 years. Half of them were male, half of them were female, and 20% of them were HIV infected. These were the drugs that Professor Scoff and his team used. This is a picture of a kid getting her injection. This is the number of drugs the kids had to take. Now, I show this to you because I know you guys are sympathetic with the kids, but I don't want this to scare you. Okay, this kid with this handful of pills would pop them in his mouth, swallow them, and then go to school. Okay, this helps us be sympathetic with the children, but please, please don't look at this handful of pills and think I'm not going to treat a kid for MDR. They do very well. But Professor Scoff looked at the outcomes of these children, and he classified them by severe disease and non-severe disease. So children with severe disease needed to be hospitalized far more frequently than children with non-severe disease. For children with non-severe disease, only half of them got an injection. Okay, so Professor Scoff only gave half of those children an injection, and of the children who got the injection and had non-severe disease, they only got it for 4 months. Okay, the mortality in the non-severe disease group was 0, and in the severe disease group, the mortality was 6.7%. Okay, so again, these outcomes show children can be successfully treated, but if you find children early when they have non-severe disease, you can probably get away with a shorter course of therapy and spare them the injection. So there's a lot of misinformation about drug-resistant TB in children. If you look in the MDR TB guidelines, children are mentioned on 2 pages as a special population. And if you look at the childhood TB guidelines, MDR is mentioned in 2 pages as an annex. So if you want to treat children for MDR, there's really no tools available. So I work with a group called the Sentinel Project on Drug-Resistant Tuberculosis, and we've created a field guide for people who are actually wanting to learn more about the practical hands-on treatment of children with drug-resistant TB. Again, I'll give you my email at the end. Email me, I'll send you a digital copy of this. Whatever you need, I'm here to help. So I just want to briefly mention this because this topic has come up a lot in the Philippines in the last few days that I've been here, that there seems to be a preference among providers. If you have a child you think has tuberculosis, even if they have a contact with a drug-resistant tuberculosis patient, providers prefer to treat them with first-line drugs and see what happens. Okay, so I understand it. I'm a provider myself. You look at a kid, you're like, this kid has TB. I'm not sure they have MDR, so I could give them these 4 pills for 6 months and see how they do. Or I could give them these 7 new drugs, including an injection, and see how they do. Well, unless I know it's MDR, I'm going to treat them with first-line drugs instead. And I will tell you that this is a risky strategy. After hearing about this from my colleagues this week, I went back and looked at some of my pictures of patients with MDR, and my patients always give me permission to show their picture. So don't worry. They know that I'm showing them. They like it when I show them around the world. So this is a woman in Swaziland, and this is her 7-month-old child. This woman had MDR TB during her pregnancy, and at the time she delivered the child was born prematurely, grossly underweight, with hepatosplenomegaly and nodules throughout his lungs on chest film. He was started on treatment for pan-susceptible disease. And the reason why is they said we never confirmed it was MDR. This child, within 2 months, developed seizures, tuberculomas in his brain, and he is now developing very slowly and very abnormally. This child never should have been put on treatment for pan-susceptible disease. Doing so hurt him, okay? And I will tell you, putting them on pan-susceptible treatment in the setting where they have a known contact or a risk factor for MDR is far more dangerous than giving them appropriate therapy. So I would caution you to think about this, not just in terms of progression of disease, but you can also cause amplification in these kids. So if you had a kid who started out resistant to INH and rifampin, and you treat them with INH, rifampin, pyrazinamide, and ethambutol, they're going to develop resistance to pyrazinamide and ethambutol. So not only are they going to get sicker, their TB is going to become more resistant. So be careful with this. I'm running down the clock, so just a couple more things to mention. A lot of what we know about the use of second-line drugs in children comes from adult studies, and unfortunately we don't have good PK data in children. This is a terrible problem in TB and in drug-resistant TB in general. There is work being done on PK data in children. What the PK results show is that we tend to underdose the children, particularly with the quinolones. So just be aware this work is going on in Cape Town, and it should impact what your guidelines end up saying. Just a brief comment on new drugs. I've been doing MDR for 20 years. I am super excited because for the first time in my career, there are new drugs for the treatment of TB that I think are going to greatly impact how we treat patients. The sad news is children will get these last. Okay, unlike other diseases where we prioritize the kids and the kids come first, in TB and in drug-resistant TB, the kids come last, and this is wrong. Okay, this is wrong. I was really impacted this morning hearing that you guys had an anthem. I love it. I want an anthem for my society when I go back home. But you talked in your anthem about the noble role of the pediatrician. And it really, it brought tears to my eyes. Medicine is a noble role, okay? And in TB, we seem to have forgotten that treating children as a priority is important to do just because they're kids. Okay, so every advance we make in drug-resistant TB, the kids come last, and this is unfortunate. I will tell you, it's exciting to be in the Philippines because with the new drug Delaminid, it's actually being tested and developed for children right here in the Philippines. So you guys are leading the way on getting a new drug into children and making sure the rest of the world gets other new drugs ready for children. So I just wanted to mention that, and I'm not going to go into that anymore. A very brief mention about adolescents. We tend to think that adolescents are just like adults when it comes to TB and drug-resistant TB. They're not. Okay, several of us did a study, a retrospective analysis of outcomes in adolescents with drug-resistant TB. They do worse than children, and they do worse than adults. And for those of you with adolescents in the room who probably think it's because they refuse to take your medications, it's actually not. Adolescents have worse outcomes because they're dying. Okay, higher mortality rates, so keep this in mind. I very briefly want to talk about prevention. So we know that children who live in households where there's drug-resistant TB are at high risk of becoming infected with drug-resistant strains. And I have never been in a country that didn't advocate for active contact tracing, emergent active contact tracing in households where there's drug-resistant TB. And I have never been in a country that actually did it. Okay, we list the contacts and that's that. We usually go to visit them once. There's a high burden of DRTB and TB in these children. And I just want to mention that there are studies that have looked at preventive therapy for drug-resistant TB. They're usually fluoroquinolone-based. And these studies that have been done in Cape Town and then in Micronesia show that a fluoroquinolone-based preventive regimen can be very effective. I'm not here to tell you you should be giving medicinal prophylaxis to children, but if you have a household with MDR TB, somebody needs to go look at those kids If those kids are symptomatic, they need to be sent for diagnosis right away. If those kids are asymptomatic, they need to be offered preventive strategies, including ongoing screening and symptom monitoring, nutritional support, and potentially in the future, chemoprophylaxis. So more to come on that. I just want to briefly mention TB and MDR TB provides us great opportunities for integrated care. We have to work with a lot of other providers. And it's important to mention most children with drug-resistant TB are actually seen by adult providers first. So I just wanted to mention that. This is a family disease and the family needs psychosocial support. Kids with drug-resistant TB need to go to school. They need to have parents who can work, who can provide them with a way to make a living. And so we need to think about all of this. So to conclude, I have several recommendations. But my biggest recommendation is that all of us in this room move away from a fear-based practice when we think about children with drug-resistant TB. We may think we're protecting children by not exposing them to second-line drugs, when in fact, not treating children ends up with dead children, okay? Children do well when they're treated, they have great outcomes. The gene expert should be your primary screening tool for TB in children. You need to allow for the treatment of high-risk children, even in the absence of bacteriologic confirmation. I know there are several treatment advisory groups that exist at the Lung Center of the Philippines and also at De La Salle. We need to think about how to coordinate that. So if people want to treat children, they have support both from within the country and outside the country. And we really need to advocate, advocate, advocate. Don't be afraid of treating kids. This is a kid with MDR that I took care of. Here he is with pericardial TB, mother had MDR. We put this kid on MDR TB, and this was him a few months later with the help of a little prednisone, when I'm being honest. Don't be afraid of treating. Be afraid of not treating, okay? When we don't treat these kids, they die. And that's all I had to say, except thank you very much. This is my email address. Please feel free to contact me, and that's the website for the Sentinel Project. Thank you, and sorry I ran over time.